Cool, so she's just putting in the keys and we should be live any minute now. And I think we are in fact live. Brilliant. So it's worked smoothly this week. Wonderful. Hi everybody, welcome to the 5th Evolutionary Medicine and Public Health Seminar. We are delighted to this week be welcoming Professor Tessa Pollard from the University of Durham. So as usual, please do post any questions you have in the chat box function, or alternatively, you can add your questions to the Google Doc and you can find that linked below the YouTube video. So Professor Pollard uses approaches from medical anthropology, public health and epidemiology to investigate everyday physical activity practices and their relationships with health and well-being. She's particularly interested in using ethnographic methods to explore and improve the impact of interventions to promote walking for leisure and travel. Professor Pollard also did human sciences at Oxford. So thank you very much, Professor Pollard, for joining us this week. And if you'd like to start screen sharing, that would be wonderful.
Okay, there we go. Thanks very much for the introduction, Gabriella, and to you and Paula for the invitation to speak today. It's particularly good to talk to an Oxford audience, given my fond memories of pursuing a broad anthropology curriculum as a student at Oxford. I'm going to take this opportunity to talk about our recent and ongoing research on walking groups, exploring their potential to contribute to health and well-being. And I also want to ask whether or not group walking can help us reduce inequalities in health and well-being. In doing so, a further aim is to illustrate the value of ethnographic research in evaluating public health interventions. Referring to the title of this seminar series, I'll be speaking much more to public health and to evolutionary medicine, though I will make brief mention of evolutionary perspectives. So for some time, my research was in evolutionary medicine, but I refocused to concentrate on physical activity, drawing on a wider range of disciplinary perspectives after writing this book. In the concluding chapter, I tried to identify the aspects of Western ways of life that we might hope to change and which might have the biggest positive impact on health. And for me, increasing physical activity seemed a clear winner. A key reason for this was the wide-ranging effects of physical activity on health, summarised in this UK government infographic, which was produced as part of the justification for the new 2019 physical activity guidelines. This change in focus led, before very long, to me embracing ethnographic methods as a way to explore the place of physical activity in everyday lives and the impact of interventions to promote physical activity. Promoting walking is a particularly appealing form of physical activity intervention. There's good evidence that walking is associated with better mental and physical health and with reduced mortality, and when used for transport instead of using a vehicle, with reduced air and noise pollution. It's the most common form of physical activity, of course, for most people, and is accessible to most people. For some time, only brisk walking was considered beneficial for health, because only brisk walking is considered to contribute to moderate to vigorous physical activity. But this review by Hamer and Cheetah demonstrated that time spent walking as a whole protects against cardiovascular disease and all-cause mortality. In 2007, a review by Ogilvy et al. Showed that walking interventions can effectively increase time spent walking. And they also found that group-based approaches were amongst the most effective interventions. However, they cautioned that it's possible that walking interventions may be preferentially taken up by better off groups. And this message was reinforced in a review by Foster et al. On recruiting participants to walking interventions. Specifically, they found, based on 47 studies, largely based in the USA, Australia, and the UK, that participants in walking interventions were, to quote them, mostly white, well-educated, middle-aged women. Middle-aged and older women have particularly low levels of physical activity, and walking for leisure declines in older age to a greater extent in women than in men, as we showed in a systematic review of gender differences in walking. This forest plot shows the prevalence of walking for leisure over the last week. In most cases, that's the timescale. For women as compared to men in large-scale studies from Australia, the USA, the UK, and the Netherlands. Results to the right of the line show that more women than men walked for leisure, and to the left that more men than women walked for leisure. And each study's results are arranged by age category, with the youngest age group at the top and the oldest at the bottom. And you can see that consistently the prevalence of walking for leisure is higher for women in younger age groups, but this gradually changes so that in older age groups, fewer women walk for leisure than men. So I'd say then that the involvement of middle-aged and older women in walking interventions is positive. However, there's a concern about the relative failure of walking interventions to recruit less educated or generally less advantaged women and men, as well as Black, Asian or minority ethnic women and men. Alongside this interest in the potential for walking as a way to boost health through increased physical activity is a growing focus on the value of being outdoors in nature for health and well-being. There's evidence that being in natural environments has a positive effect on mood, as shown in the results of this meta-analysis, which synthesizes the results of studies that examine the effects of undertaking the same activity, mostly either running or walking, in natural versus synthetic environments. And what you can see here are effect sizes for a beneficial effect for each outcome. So for a few years, there's been a growing interest in promoting exposure to nature as a public health measure. For example, Barton and Pretty asked in a much cited study published in 2010, what is the best dose of nature and green exercise for improving mental health? And in this vein, group walking is now promoted as a form of green prescription. Returning to an evolutionary perspective, this movement built partly on E.O. Wilson's biophilia hypothesis. His proposition in the 1980s was that humans have an innate tendency to focus on and affiliate with life forms and lifelike processes. Subsequently, the hypothesis has been taken up widely, as in this recent book, and refined in various ways. For example, to suggest that humans have a preference for the kind of structural landscape features, such as trees, that would have provided resources or safety in environments in which humans evolved, or to suggest that we have innate affinities with specific habitats, particularly savanna or forests, because of the resources they provide. Others emphasize the unfamiliarity of urban environments in evolutionary terms, and suggest that natural environments are preferred simply because of our evolutionary history in such environments. Different versions of the hypothesis place a different emphasis on the degree to which such affiliation is innate or merely biologically prepared and largely learnt. Critics go further to suggest that our relationship with nature is socially constructed and variable. For example, in this country, there's a shared understanding of walking in the countryside, which can be linked to a long literary history characterizing walking as a virtuous activity that's simple, good, natural, and healthy, rooted particularly in the Romantic movement of the 18th and 19th centuries. Nevertheless, as Sarah Bell and colleagues have explored, while these understandings are widely shared, they are not universal and depend on sociocultural narratives and life experiences that shape understandings of nature. There have been studies, for example, showing that people with limited childhood experience of forests are less likely to enjoy them as adults and are in fact anxious when visiting forests. There is then a strong argument that affiliation with nature or green environments is acquired through our lives and varies considerably. Whatever the source of a positive response to nature, the upshot of recent emphases on increasing walking and increasing exposure to nature is that public health professionals and others are keen to promote outdoor group walking, and outdoor walking groups usually seek out green spaces for at least part of their routes. The biggest walking group schemes are Walking for Health in England, at Heart Foundation, Walking in Australia. Walking for Health, which runs short volunteer-led weekly walks that are free to attend, is one of the largest physical activity interventions in the UK, and Paths for All in Scotland also run a large number of similar outdoor group health walks. Nordic walking groups involving walking with poles are a rather more vigorous form. And another major type of group walking is mall walking, in which groups walk inside in shopping malls or malls, usually before the shops open. Mall walking is particularly popular in the US and also found in Canada and Australia, particularly in areas where the weather can make outside walking challenging. Walking for Health in England is currently forging connections with the new NHS social prescribing programme, currently being implemented as part of the NHS long-term plan. At the core of social prescribing is the linking of patients into local community groups. And there's particular attention being paid to green social prescribing, which includes linking into walking groups, and which is currently being funded by a £4 million investment in test and learn sites. A systematic review by Cassavou et al. Showed that walking group interventions lead to an increase in physical activity. So in this plot, if an intervention led to an increase in walking, it will have a positive effect size. And you can see that the average effect size is a moderate one of around 0.5. And a systematic review by Hansen and Jones showed that participation in walking groups improves the number of outcomes linked with cardiometabolic health, although not all, as well as improving depression scores. And they also showed that walking groups have low levels of dropout. Considered as a public health intervention then, we can say that walking groups are successful both in contributing to improved health and well-being and in appealing to large numbers of people. As for other walking interventions, demographic data from the two biggest walking group schemes show that most participants are aged 55 to 79 and that more women than men participate. If we look at participation in Walking for Health groups, you see a clear gradient across socioeconomic status, with a much smaller proportion of walkers living in more deprived areas. As a consequence, in England, there are concerns that walking groups may contribute to health inequalities. Interestingly, there's much less evidence of this socioeconomic gradient in participation in the Heart Foundation walking groups in Australia. Coming to my aim then today, this is to examine how group walking finds a place in people's lives, asking how it successfully recruits such large numbers of walkers. Increasingly, qualitative research, including ethnographic research, is being used for this kind of purpose as part of a process evaluation of complex interventions to open up the black box and explore how interventions are experienced and work for participants. And then secondly, I also want to consider the issue of socioeconomic inequalities in participation in walking groups and explore why they exist and whether there are ways of increasing participation by less advantaged groups and avoiding potentially exacerbating health inequalities. I'm going to talk about 3 studies. The first was a meta-ethnography to synthesize the body of qualitative research on walking groups. And the second is our own ethnographic study of women's experiences of outdoor walking groups in relatively deprived areas of the northeast of England. We actually conducted the ethnography first, and it was included in the meta-ethnography. But for the purposes of today, I'm going to consider the two the other way round, as the first gives an overview, and I want to build on that to talk about some specific insights from our study. And then thirdly, and finally, I'll talk about our ongoing ethnographic research, examining experiences of social prescribing, in which we specifically consider social prescribing into walking groups. First then, to talk about our meta-ethnography of experiences and understandings of walking groups, which was conducted with Connie Gould and Steph Morris. We set out to synthesize existing qualitative research on group walking. And to achieve this, we chose to undertake a meta-ethnography. So this is a method developed by Noblet and Hare as an explicitly interpretative approach to research synthesis that aims to facilitate conceptual translation between studies. Meta-ethnography aims to retain the inductive approach of ethnography, treating the interpretations offered by the authors of the original studies as data to be synthesized. Our paper reporting on this work was published last month. Our first step was to identify previous qualitative research on walking groups by systematically searching the literature, which resulted in the inclusion of 22 studies, including our own. We included studies of small walking groups, but excluded studies of Nordic walking groups. We also included studies in which people who weren't members of walking groups were asked about their views of them, and 2 such studies were we found and were included. You can see that most of the studies were conducted in the UK, many with Walking for Health groups, while others came mainly from the USA, with one from each from Australia and Ireland. Noblet and Hare laid down a number of steps necessary to the process of conducting a synthesis by meta-ethnography, and those are the steps we followed. They involved becoming deeply familiar with the original papers, extracting the constructs or concepts or themes presented by the original authors, looking at how those constructs could be translated across studies, and then developing our own analysis based on those translations. This table shows both our translations of concepts from the original studies and then how we brought them together to create 5 constructs of our own on which our line of argument analysis was built. So these 5 constructs were seeking and enjoying health and fitness, attachment to walking, providing purpose and confidence, a peaceful and contemplative shared respite from everyday life, and mobile companionship. So first then, we found that seeking and enjoying health and fitness featured as an important reason for people to engage with walking groups. This seems particularly key in the process of joining a group, as Ware and al. describe. In their study, mall walkers talked about joining their walking group as a way to stay healthy, lose weight, and keep fit. Some walkers felt they needed to undertake more exercise because of increasing age. And as one of the participants in Coppleton's study noted, "I should be doing exercise at my age. It's good for me." Priest conducted fieldwork with a walking group organised by a mental health day service in the UK, and she develops the notion of striving, referring to people actively working to make themselves feel better. Importantly, the sense of striving was shared with others in the group. So one participant said, "We've all had mental health issues. We're all trying to recover and do our best to move on." This concern with seeking and enjoying health and fitness through walking reflects public health messages and more general discourses about the importance of keeping active in order to pursue good health, particularly in older age, and the recent emphasis within health promotion on walking as an accessible form of health promoting physical activity. And just to say, the details of all the studies I cite here are, of course, in the bibliography of our paper. A positive prior embodied experience and understanding of walking emerged as an important factor for participants in a few studies, and walking was generally mentioned as being familiar and enjoyable. Group walking tended to become incorporated into a weekly routine, providing a valued sense of structure, and was also experienced as an achievement, leaving participants feeling energized and confident. As one of Grant et al.'s Health Walk participants said, "That's what you do on a Monday morning, and it's just part of the rhythm of your life, a lovely way to start the week." So there was a familiarity and predictability to the rhythm of this routine that was in itself pleasurable. Macpherson highlighted the sense of achievement and pride of walkers with visual impairments and their guides on group walking holidays in the Lake District on reaching a mountain summit. But this feeling wasn't unique to this group and was also felt by members of Walking for Health groups who undertook much gentler walks. As the participants in Hines and Allibone's study said, "When I finished, it's a job well done and I can feel proud of myself." These accounts partly reflect a task-oriented approach to the group walk, but overall there was what Steph described in our own ethnographic study as a broader sense of a boost. A strong sense of a peaceful and contemplative shared respite from everyday life emerged through the contributing studies, and this was summarized by Doughty as sharing therapeutic space. Priest found that for her participants, getting away from unnatural environments could be part of getting away from difficult everyday lives. One of her participants said, "Less houses or society and more wandering through fields and over stiles means less anxiety and more mental freeness, less self-consciousness." As we also saw in Ireland et al.'s study of a walking group for people affected by breast cancer, they say movement from the urban to rural, unnatural to natural landscape with all its attendant sensations was conducive to feelings of calmness, healing, and freedom. There was a consistent feeling that group walking afforded an escape from everyday life and from urban environments, and an appreciation of a period of peace and contemplation that was linked with moving purposefully but mindlessly with other bodies through green environments. In this understanding of group walking as a contemplative shared respite, we also see elements of the liminoidity ascribed to pilgrimage by anthropologists Victor and Edith Turner. Liminoidity is characterized by them as a potentially transformational, voluntary separation from society, a powerful and bounded form of symbolic engagement leading to an experience of flow. And drawing on their work, Frey describes pilgrims' strong sense of the here and now and an out-of-time quality, as well as a feeling of connection with place, with senses open to the environment. And there's a striking parallel here with descriptions of group walkers. Nearly all the papers in our analysis highlighted the importance of social connection in group walking. Ireland et al. Developed the idea of shoulder-to-shoulder social support to describe how this phenomenon was realised for women affected by breast cancer in this case, as in some others, enhanced by a shared experience of illness. A sense of acceptance and belonging emerged across several studies, including in priest's work, encompassing both the connection with other walkers and with the wider landscape. Doughty introduced the notion of fleeting sociability, arguing that moving together relaxes the experience of talking and silence, the absence of eye contact and the companionship of moving together, reducing the intensity of interaction. So walking groups are characterized by switching between companions and conversational topic as pairs or small groups spend some time together, and then a change of direction or pace results in a natural shifting of bodies to a different formation. And this makes for a transient and light form of social connection that's particularly appreciated by walkers. And a feeling of safety and security, which was important to walkers, also emerges from the companionship of fellow walkers and also from being in nature or in mall walking in the safe space of the mall. We see here a further parallel with the experiences of pilgrims conceptualized by the Turners as communitas, a commonality of feeling associated with being with other pilgrims outside the mundane structures and social independence of everyday life. And it's interesting to reflect on the notion of a common mission here, so related to religion, or more broadly spirituality in pilgrimage, and related to health in group walking. Building on these findings, we argue that participating in a walking group provides a set of experiences that together constitute a specific form of what we've termed communal therapeutic mobility. In doing so, we build on Tony Gatrell's concept of therapeutic mobilities, a term he specifically developed in relation to the assemblage of an embodied experience of walking within often a green environment, also with elements of sociability, for example, with family members or with a dog. But Gatrell didn't consider walking with larger groups. And we argue that communal therapeutic mobility is something more than the therapeutic mobility described by Gatrell, and is specific to moving with a group, as is clear, I think, from our analysis. In naming it, we refer to Gatrell's notion of therapeutic mobility and to the Turners' communitas. Communal therapeutic mobility isn't simply the accumulation of the constructs I've outlined. Rather, I'd argue that an initial focus on health and fitness, and often attachment to walking, is transformed through the experience of group walking into an emergent communal therapeutic mobility. This isn't to say that the initial focus on health and fitness falls away and should simply be considered as the motivation that led to joining a walking group in the first place, but that over time walkers change their understanding of group walking from initially considering it as an instrumental way to gain health and fitness to valuing it for the experience itself. An association with health and understanding of walking as good and natural continues to underpin this experience. So communal therapeutic mobility does not then reject or resist logics that emphasize individual responsibility for health, but it does transform the performance of physical activity to provide a form of pleasurable self-care. Importantly, we recognize variation in the experience of communal therapeutic mobility between different walking groups, for example, between indoor and outdoor groups. And our analysis also helps us think further about socioeconomic inequalities in access to walking groups, partly by thinking about the role of class in the production of communal therapeutic mobility. Understanding why certain people are less likely to belong to walking groups is, of course, difficult based on research with people who do belong to walking groups, but we can get some clues. And the two studies in our review that asked people about their views on potentially joining a walking group are particularly useful. And here I'm also going beyond what we said in our paper and drawing on a body of research applying social practice theory as a way to look at engagement in nature, sport, and the pursuit of healthy lifestyles. And I've included some references on the slide here. Thinking first about engagement with pursuit of health and with active aging discourses, Waring et al. Have argued that the idea of investing in future health is of limited relevance to those dealing with a precarious present. And Katz has shown that opportunities to engage with the commonly shared ideal of active aging are constrained for older people with lower incomes or other disadvantages, partly because of other priorities in their lives. Wiltshire et al.'s ethnographic work showed how middle-class school pupils reproduced discourses about needing to do sport and stay fit, while those in the lowest socioeconomic positions identified with ways of being that were largely opposed to these dominant healthism discourses. Given the evidence that engagement with these discourses is commonly seen in group walkers, we can see that walking groups are more likely to recruit for this reason from the more middle classes. Similarly, understandings of walking for leisure are classed. For example, Judith Green has shown how walking for leisure, including rambling, is a generally middle-class occupation in this country. It may then be a much less thinkable pursuit for those outside the middle classes. And as we've seen, there's variation in the meaning of nature and thus in its appeal for different people. Indeed, some kinds of nature were experienced negatively by some walkers in the studies in our synthesis. For example, Iwata et al.'s participants belonged to a Woodland for Health programme in Ireland for people experiencing enduring mental ill health. And echoing other studies, many participants experienced a sense of peace and calm, and they enjoyed the beauty and quietness of the forest, the lack of people, the sense of escape and freedom away from everyday life. But one participant in the small group felt cold and uncomfortable when walking through tall and dense conifer plantations, and other participants mentioned the darkness of these sites. It seems likely then that an underlying affiliation with nature may be an important factor in engagement with some walking groups. Notably, the countryside is often perceived as a middle-class space, and it's possible that exclusion arises because historically othered groups take for granted that such settings are not for them. And there's certainly evidence of this in relation to national parks, as shown by Askins et al. The biggest concern expressed about group walking in the studies we reviewed was social apprehension, particularly concerns about fitting in when contemplating joining a group. And this is illustrated in Curry et al.'s study of new mothers from low-income areas of Scotland who were asked to consider the acceptability of walking groups, who were afraid that no one might speak to you or that you might turn up and you don't know anybody and it's awkward. And in an American study by Brown et al. That sought views about potentially joining a walking group from people with a serious mental health diagnosis, most of whom were African-American men, concerns were also expressed about joining a group being socially awkward. In Hansen et al. Study, similar worries were experienced by walkers who had chosen the option of joining a walking group, having been referred for exercise by their GP, with the first session a hurdle to be crossed. And in other studies, walkers reported adverse experiences of cliques, as they called them. So, while moving sociability was hugely appreciated by most walkers, the sociability of group walking, particularly fitting in, was a source of worry for others. And it's easy to see how such concerns might constrain more disadvantaged groups, particularly given likely understandings of group walking as a white middle-class practice. So these are all reasons for variation in the accessibility of communal therapeutic mobility. And I think it's possible to see how together they make walking groups spaces for the more affluent, more educated, and more advantaged. And just to say, I want to be really clear that while dominant understandings consider individuals responsible for their own health-related practices and would see individuals as responsible for making decisions about joining a walking group or not, I'm not suggesting that individuals are making good or bad choices, but drawing on social practice theory and suggesting that these different dispositions towards group walking are structurally and socially created. So group walking won't appeal to everybody. There may be ways of widening its appeal, but that will be challenging. And it could be that other types of interventions are needed to reach different groups of people. And one possibility I'll throw out is walking football groups, which are now being established by some Premier League football clubs who've drawn on the strong loyalties of their fans to set up groups, attracting large numbers of older men in lower income areas. To conclude on the meta-ethnography, we identified a complex assemblage of people, movement, and context in group walking that produces communal therapeutic mobility and maintains a commitment to group walking. But we also show that group walking will not work well for everyone and suggest that communal therapeutic mobility in group walking is more accessible to more advantaged people. I want to go on to talk about our own ethnographic study briefly, for which Steph Morris conducted the fieldwork and led the analysis. In this study, we worked only with women, driven by an interest in older women's physical activity, and our findings provide further insights into what walking groups have to offer specifically to women in middle and older age. Steph Morris conducted participant observation on group walks, conducted mobile, mostly unstructured interviews on walks, and more formal semi-structured interviews, mostly in a more traditional sit-down mode. She then led a thematic analysis. And we also asked women to wear an accelerometer for 7 days so that we could look at the contribution of group walks to moderate to vigorous physical activity. Steph worked with 5 different groups. All were based in areas that were within the 40% most deprived, according to the Index of Multiple Deprivation. The BME, as they referred to themselves, group was just for women. The other groups were mixed, but did include more women than men. At the community centre group, based in an ex-mining village, Steph also interviewed 2 women who were members of the centre but didn't join the walking group. We collected sociodemographic data from 51 women. In line with other studies, most walkers were aged between 61 and 80, and most were retired. When we looked at the Index of Multiple Deprivation quintiles for women's home addresses, it was clear that most women lived in areas that were not within the 40% most deprived. So this shows that they'd come from more affluent areas to join the walks. And it seems then that even though walks took place within more deprived areas, they attracted mostly more advantaged women. However, there were differences between groups in this, and members of the semi-rural community centre group in the ex-mining village were more likely to live locally in more deprived areas than members of other groups. We conducted a descriptive analysis of the accelerometer data because of the small sample size, and this graph simply shows that on the day of the group walk, women's moderate to vigorous physical activity was higher than on the other days of the week, and the walk contributed around 40 minutes of moderate to vigorous physical activity on average, of an average weekly MVPA of 170 minutes, so quite a substantial contribution. Retired and old women appreciated this opportunity to be active because they didn't want to, and I'm using their terms here, sit around with their feet up all the time, and had a desire to keep active and fight old age. And these women are clearly, again, engaging with discourses around active aging. Overall, we found that the walks supported women members through becoming spaces of sharing, healing, and enjoyment, and what I would now call communal therapeutic mobility, having conducted the meta-ethnography. So just one quote I'll read out from this slide. "You feel brighter and you feel better in yourself when you've done it. When you get back, you're always really bright and happy and feeling energetic." What we identified as a new contribution of our analysis was the finding that group members' appreciation of these aspects of group walking was often intimately linked with their life circumstances. And I'll illustrate this by drawing on just a few of Steph's profiles of some of the participants. Starting with Iris and Beryl, who were both retired. Iris's participation in the group was a consequence of the death of her husband, Colin, and she said, "I think as long as Colin lived, I would have stayed with Colin. I don't think I would have joined. Without coming out twice a week now to at least walk with the group, I think I would still be moping around. You know, I really do. It brought me back to life." And Beryl echoed this and gave us the term lifeline, which we used in the title of our paper. She said, "I think it just gives people a lifeline, especially those people that live alone, that's lost wives or husbands, you know. I feel lucky that I found it." So this idea of providing support and sustenance at a difficult time was a theme in our findings. Marianne joined the community centre in the Pit Village after becoming unemployed because of help offered there with job seeking. She suffers from what she terms mental health problems, and she said, "I don't like big open spaces and lots of people. I like to be just in my little close-knit group because there's people here that I know and because they're a nice group, so that's why I come. It's good therapy for my mental health." So Marianne's desire to attend the walks every week was connected to her unique social circumstances and mental health. She took comfort from this small group as a safe space, which provided her with a routine and familiar social contact. So often people had come to walking groups at a time of change or disruption in their lives, and the sharing, healing, and enjoyment provided by the walking group gave them something that was particularly valued at that time in their lives. Biographical ruptures, such as retirement or bereavement or a diagnosis of a mental health problem, created zones of possibility for taking on a new activity. It's previously been recognised that life transitions can be important moments of opportunity for interventions, but our analysis shows that these moments aren't times when people become simply a blank canvas on which it's possible to inscribe new healthy habits, but times when a resource such as a walking group and the communal therapeutic mobility it offers might become valued if it works well for people. Opportunities to pursue the kind of self-care to which group walking could contribute are constrained by social disadvantage, as I've outlined already, by less engagement with discourses around health and active aging, and with the notion of investing in future health, by dispositions towards walking for leisure and nature, as well as by concerns about fitting in with other people in a group. And such constraints can be partly practical. For example, Rose, another member of the Pitt Village Community Centre who didn't engage in the walking group, explained that she couldn't join the group because of her role as a full-time carer for her disabled daughter. She said she couldn't guarantee being able to join the group at a fixed time each week. So the idea of engaging with walking for health is less likely to resonate at a time of biographical disruption for those living in disadvantaged circumstances. Within these zones of possibility, joining a walking group was also contingent on social and/or material resources. So lack of access to transport to the starting point of walks for women who didn't own a car was mentioned as a practical limitation. And the process of joining a group tended to be dependent on encouragement or signposting from friends, community members, or formal or informal groups to which women belonged. Wiltshire and Stevenson, in their study of engagement with parkrun, have suggested that those in lower socioeconomic groups may be less likely to encounter what they term the mundane, incidental, everyday interactions that encourage participation. The community centre walking group offered a way around this problem, and we agree with Hanson et al. That one way to increase recruitment into walking groups in disadvantaged areas is for organisers of walking groups to engage with existing community groups. Our main conclusions from this study are therefore about the key role of times of change or biographical ruptures in the process of joining a walking group, and the importance of a good fit with existing life circumstances in sustaining membership. And that fit is likely to be better for people who are relatively advantaged for the reasons I've explored. Finally then, I want to talk a bit about some data on social prescribing into walking groups. So this was collected as part of our ongoing mixed methods project to evaluate a social prescribing intervention in an area of high socioeconomic deprivation, which is led by Suzanne Moffat. As I mentioned, social prescribing is currently being implemented on a large scale within the NHS amidst big claims for its potential to free up GP time and reduce health inequalities. It involves GPs referring patients to link workers who spend time with them and help connect them into local community groups and services. Social prescribing is expected by the government to reduce health inequalities by supporting those most in need. But there's relatively little to research to show that it's effective in relation to health outcomes, and even less to show how it might work for participants. So that's why we undertook this study. These are the details of the bigger mixed method study, which is evaluating a social prescribing intervention for people with long-term health conditions. So this particular social prescribing intervention predates NHS social prescribing. Qualifying patients are referred in from primary care and then meet up with a link worker who's expected to support service users for an average of 18 months. And this support usually involves using motivational interviewing to help the service user identify goals, often around food and physical activity, and can also involve linking into local services such as nutrition classes or debt advice. Suzanne Moffat and I are leading the ethnographic element of the study, and I'm going to draw in some data of that study, most of which were collected by Dr. Kate Gibson, who conducted participant observation and interviews with 19 service users with type 2 diabetes over a 15-month period, and is currently writing those data up. And in addition, I conducted 6 interviews with organisers of local community groups with which service users can potentially be linked, including walking groups. And I also joined a local walking group, which was attended by one of Kate's participants. Our fieldwork was brought essentially to an end by the national lockdown in March, so all these data predate COVID and social distancing. I'll say a bit about the walking group first. So this group walks from a community centre in a deprived suburban area through streets of semi-detached houses and across the local moor. Kate's study participant Geeta is a regular at the group. She's in her 60s and came to the UK after attending university in India. She also attends a large number of other group activities on a weekly basis, often with other friends of Indian origin. She joined the walking group and her other groups following her retirement from a job in the voluntary sector, partly as a way to occupy her time. As we walked, she and the other walkers would point out places they'd known for years, telling me about where they used to work and where they used to take their children. The group consists mostly of retired women with a few men. Many of the walkers worked in education, healthcare, or in social work. And like Gita, many of the women in the group attend a variety of activity sessions, and they swap information about different groups as they walk along. Although they also talk a lot about how different groups have been shut down in recent years, and for example, how all the local swimming pools have closed. Gita enjoyed the walking group so much that she and her friends arranged a separate regular group walk of their own at the weekend in another park, which Kate was also able to join one day, where she took this photograph of the swans. The main group was organised by the arm of the local council that promotes physical activity. However, their budget has been cut and they've lost their walking officer. So over the 6 months that I walked with the group, the woman who normally leads the walks planned for volunteers within the group to take over leadership. And to this end, the council ran a walk leader training day. However, there's a lack of confidence amongst the volunteers. And when lockdown came along, the group was still reliant on their leader from the council, even although it wasn't clear how long this would be sustainable. Notably, Gita did not join the group through the social prescribing intervention. She saw information about the walk in her GP surgery and turned up the next week at the neighbouring community centre where the walk starts and finishes. And this is the same for many of the walkers, though some of Gita's friends have joined through her recommendation, and some of the men also joined through word of mouth. Previously, there'd been another walking group in the area, run by one of the two organisations that delivers the social prescribing intervention from its premises. And that group was attended by social prescribing service users. It was led by a British South Asian woman who was out of work for a while, and it was a women-only group attended by both British South Asian and white British women. People came along to socialise and have a gentle walk around the park. A senior link worker told me that running the group from their offices made a big difference, as service users could come somewhere familiar and often see their link worker before or after the walk. The group ran successfully for a couple of years, but stopped when the leader went back to work and the group petered out because they couldn't find another committed leader. So just to pick out a few things here, walking groups within the area appeared to be offering the kind of communal therapeutic mobility I recognised from our previous work. The two groups I learned most about, and I only heard of one other group running in the area, which is quite big. So these two groups worked well, and they benefited from being linked to familiar community locations. But despite keen members, sustainability was a real issue because of the need for organisers and leaders and because of a lack of funding. Also important have been changes within the social prescribing intervention. So changes to the funding model have required the provider organisations to recruit more clients than previously, reducing the time link workers can spend with their clients, though they still have far fewer clients than NHS link workers. And the intervention also suffers from high staff turnover, which has actually been exacerbated recently by link workers moving to work as NHS link workers. The senior link worker expressed a desire to put on more groups, including a new walking group, but she said, just with staff turnover and different things that have happened in this year in particular, like a lot of that has been lost this year, meaning the provision of services like the walking group. We've had other things to prioritise, or we're just managing caseloads and hitting targets. Lack of time in a landscape of ever-changing provision of activities such as walking groups also means that link workers find it difficult to keep track of what groups are running where, and results in the linking of service users into relatively few well-established services, particularly a 10-week gym-based programme. Over the course of the ethnographic fieldwork, we found very little evidence of people being linked into walking groups through social prescribing. Linking into walking groups is also particularly unlikely to occur for the least advantaged and least healthy service users. Kate's analysis of her data provides powerful, detailed evidence on how difficult it can be for people living in poverty to engage with their link workers and take up activities offered by the local authority or voluntary organisations, particularly without really intensive support from a link worker. Social prescribing service users living in poverty were concerned with more immediate and urgent problems, such as debt or overwhelming caring responsibilities, and were rarely in a position to engage with activities to protect their future health. Reflecting this difficulty, the senior link worker told me that if they were to try to set up another walking group, to be sure that it would be worth their while, they would need to, in quotes, pick out people who are going to turn up, have the time, who've shown in the past that they will access and turn up to appointments. And while this makes good sense for the service provider, it illustrates how well aware link workers are that some people have great difficulty engaging with this kind of service and how much harder it is to support those people. The opportunities for social prescribing to reduce health inequalities through linking into walking groups were then severely lacking. And this isn't to say that green social prescribing into walking groups and other activities couldn't work, but first of all, such groups need to exist and they need to be resourced. Years of cuts in government funding has meant that financial support for this kind of activity has been very limited over the past decade. If social prescribing is to rely on the existence of such community groups, they will need to be funded. Then link workers would need to have time to support their clients into the groups, for example, by going along with them once or twice. And when that's happened in the past, it's been really successful, but link workers in the intervention we evaluated currently have very little time available for this kind of thing. And as I said, NHS link workers are likely to have even less time available for those referred to them. Even with support from their link worker, those on the lowest incomes and living in the most difficult circumstances are less likely to access services such as walking groups for the reasons I've discussed. So even if social prescribing were to successfully link people with long-term health conditions into walking groups, it's unlikely in so doing to contribute to reducing health inequalities. To conclude then, I have, I hope, shown how walking groups work as a successful intervention for some people, particularly the retired and well-educated, providing an experience of what we call communal therapeutic mobility. Moments of biographical disruption, such as retirement or being widowed, provide windows of opportunity for a new engagement with a walking group. And in this sense, walking groups can provide a shared pathway to health that's experienced as enjoyable self-care and not just an activity undertaken because it's calculated to reduce later risk of disease. To go back to my title, group walking can be a shared pathway to health. However, walking groups don't work for everybody for various reasons that are not easily understood by thinking simply about barriers at the individual level. Instead, an approach drawing on ethnographic data and social theory shows that there are a variety of socially produced reasons that walking groups are particularly appreciated by older, relatively affluent people and are not as well used by people from the poorest sectors of society who also have the poorest health. Group walking may be, in Judith Green's words about general public health messaging around walking and health, quotes, less likely to resonate with the desires and needs of targeted populations, unquote. The pathway produced by walking groups is not then shared by everyone. Nevertheless, I've also described some walking groups that successfully serve or served more disadvantaged groups of people, thinking particularly about the Pit Village walking group from Steph Morris's fieldwork and the group run by the social prescribing service provider from their offices, both of which were based at familiar community centres that people visited for other reasons. So if we want walking groups to provide a version of communal therapeutic mobility to more people and potentially to reduce rather than exacerbate health inequalities, this seems like a positive way forward. Finally, there is potential for social prescribing to facilitate recruitment into walking groups, but there's also a variety of challenges to overcome, starting with ensuring that there's enough funding to allow local authorities and community groups to set up and lead walking groups. Having said that, we shouldn't put all our eggs in the basket of walking groups. In order to promote relatively gentle, accessible physical activity, it may be useful to offer other walking activities that have a different kind of appeal, such as walking football. And we should be aware that investing in health is not a priority for all, and think carefully about advertising such groups as being for health, considering instead communicating the possibilities for fun and pleasure in moving together. And I know that that's increasingly being done by groups run by Walking for Health, for example. This analysis was possible because of our use of qualitative methods, including ethnography, to provide a deep understanding of how group walking and social prescribing are experienced. And I hope I've convinced you, if you need convincing, of the value of this approach. And I'd like to finish by saying thank you to the great people I've been working with on this over the last few years. So Steph Morris, Connie Gould, Suzanne Moffat, Kate Gibson, Janelle Wagnold and Rachel Ward, and of course thanks to our walking research participants. Thank you very much.
Thank you so much, Tessa. That was absolutely fascinating. My grandma is actually part of a walking group, and I don't think I've ever thought about it quite like this before, so a lot of food for thought. Thank you. We have some time for questions, so I'm going to get a start. A lot of you have been asking questions on the Google Docs. Please feel free to continue asking or respond, and you can also ask on the chat box below the YouTube channel. So our first question is by Ben Castan, who said, "Thank you very much to Tessa for a fascinating presentation. Thinking about the biographical ruptures, are you able to comment how this past year may have impacted the predictability and routine enjoyed by group walkers and public health restrictions?"
Yeah, that's a really interesting question. As I said, our fieldwork sort of came to an end as lockdown started, but I was in touch with the woman who leads the walking group that I joined, and to answer specifically in relation to that group, they did carry on communicating with each other electronically. I don't know if that was everybody, but that carried on through lockdown, and it will be interesting to see how that emerges as we come out. But yes, of course, this has been a huge time of disruption, of biographical disruption for all of us, which is affecting our physical activity practice in all kinds of ways. And I know being outside and walking has become more important for a lot of people, though, of course, that has to be distanced. So I think it's really hard to predict what the future might bring, but it's certainly possible, I think, that some people, as the government has hoped, people will get the taste for walking, will have enjoyed walking during social distancing, and may continue that in various ways. I know the government hopes that will carry on in commuting to work and to school, but it potentially may also to lead to people joining walking groups.
And just a follow-up question, actually, just of mine, not related to Ben, but could you talk a little bit more about how people are communicating to organise these walks? Because I know you mentioned setting up from community centres and things, but you just said that people are being in touch over like online and things like that. Do people have WhatsApp groups or email chains?
Yeah, so I think that changed at lockdown. So as I hadn't come across it happening previously, so I don't think it's a routine part of walking groups, but it's, as we all switched online, that certainly happened. And unfortunately, we haven't been able to pursue that, because it would be really, really interesting to see if that excluded some people, for example, and how exactly it worked. But I think I heard that it involved people engaging with exercising online together as well, following Joe Wicks and that kind of thing that's been going on.
Yeah, thank you. We have another question. As a Brit, mall walking seems strange to me. Do you know of any studies that have analysed the health benefits of this compared to those who walk outdoors in groups? It would be interesting to compare, to be able to assess if the benefit is to being in groups or being in nature.
Yeah, I think it's difficult to separate those things. I think that it all comes together, and that of course means that mall walking must be rather different from outdoor walking. And as I said, it is mainly done, I think, in the US and Canada and Australia, and it's often, in the winter when there's a lot of snow outside, it's a good environment for walking in, so people can carry on walking. It's also something that's done generally by older people than outdoor walking, and it happens usually before shops open. So we talked about the safety that people that can't feel comes from nature, and the security that people get from that, but that also comes from being on a very flat surface in a mall, for example, in a shopping mall, and people do laps of the mall, and reading the studies that contributed to our meta-ethnography, that's in some ways not dissimilar to the outdoor group walking. People walk with companions and shift around and meet up for a coffee afterwards, and those are all very familiar to the outdoor groups as well. So I think it all comes together. It's hard to separate out what comes from the sociability, what comes from the environment.
Yeah, I mean, also as a Brit, the idea of mall walking is very strange to me, but I hadn't really thought about flat surfaces and obviously what you were saying about feeling safer, not necessarily in nature if you haven't grown up around it. So
yeah, absolutely, it's very predictable. And I think actually a lot of people it's not just weekly, people turn up every morning. And so, you know, it's again a part of that routine. So for retired people, you know, who used to go out to work, that's one of the things that people talked about in those studies was, you know, I turn up at a fixed time every morning, I meet in a group of people that I'm very familiar with, and it's really important to them for that reason as well.
We've got a question from Rose Stevens, which reads, you mentioned that impacts on different dispositions towards joining a walking group are mostly structural rather than individual. What either policy recommendations or individual walking group initiatives would you promote to try and overcome these structural barriers?
Yeah, that's a really good question, isn't it? Because clearly the implication with what I was saying is that it's not easy to overcome those barriers. And the best way that we could see that was overcoming some of that was going to groups that already exist within community centres or wherever they exist in more low-income areas, and engaging with people who are already familiar with each other and who might be interested in going out for a walk together. And that does seem to be something that works. I think that's one way forward. Yeah, beyond that, it's difficult to think of things. There are schemes which have tried befriending strategies where people go, if people join a walking group, they are befriended by someone who's allocated to them to help them get over that initial hurdle that perhaps doesn't help them get into the group. But social prescribing could be really useful there as well, because, you know, if that works really well, and if link workers have time, then, you know, they can talk to people about what they might want to engage with, and if walking groups are appealing, they can go along again to the first meeting, find out what's happening, and try and integrate people with the group, and perhaps even go along for the first couple of times. So there's a few ways in which it might be made more accessible, I think. But there are also real structural differences that might mean it just won't work for everybody, and that's, you know, why I was mentioning other kinds of walking interventions that might appeal to different groups of people.
Brilliant, thank you. We've got another question. I'm going to skip because it's relevant, and I'll come back to your other questions after. So a question from Abby Page. A topic I work on is social support, and it seemed very interestingly that the walking groups providing this type of support, I assume, are providing this type of support, but also excluded people from different SES backgrounds who felt that they wouldn't fit in. Sorry. So how, in your opinion, do you run a social support intervention of some sort which uses support systems from within communities which aren't middle class, affluent, etc., i.e. the background of researchers? I ask, this is Abby, because this is something that I think about a lot. How do we think outside the box to create an intervention which will break down health inequalities? This has all been super interesting. Thank you.
That's a big question, isn't it? And I'm afraid I don't have good answers to that. But I think it's, you know, this is what I said today, I think, a way to start us thinking about that. And just, I think it's really important not to just assume that if you set up a group doing something that seems on the face of it appealing, that it's not necessarily going to appeal to everyone. So if you do this kind of qualitative research, you can maybe start to understand what might work better for different people. So I don't have an answer to that, but I totally agree that this kind of group intervention can be really powerful. And I think there are things, other kinds of groups that happen in the area in which we're doing the social prescribing study, and people often talk about knit and natter groups, for example. There were chair exercise groups going on as well that the social prescribing provider was putting on. So there are different kinds of things that work for different people in different places, but I think probably we have to be quite creative and careful in thinking about those.
Yeah, I mean, perhaps a future for collaboration in two quite different areas, what Abby studies, but united by similar interests in looking at health inequalities and why groups might not be partaking in different activities.
Mm-hmm.
So moving on slightly, this is not a question about walking, but about creating a mixed method study. So you mentioned how important it is to have ethnographic detail in your studies. We don't hear from that many researchers in the seminar series who are using mixed methods techniques. Usually it's one or the other. So could you elaborate a little bit or discuss on how it was put together? Obviously you did it with others, so did you divide the work completely, or did you all work on a combined framework and then after that do your own sections?
Yeah, so Suzanne brought the social prescribing evaluation together, and so it was her inspiration to do the mixed method study. And we have different teams working on different work packages within the study. So we have two quantitative work packages and an ethnographic work package, but we do work together very closely as a team. So we have team meetings, and we have worked quite hard to have the two sides of the analysis and data speak to each other. So there have been things that have come out of the ethnographic data, and particularly things, as we observed, in the changing of the social prescribing intervention over time that have led to predictions to be tested in the quantitative data, and also that there have been things that have come out of the quantitative data and we thought, well, where's that coming from? And because the ethnography was still ongoing, we were able to go out and ask those questions. I think talking to each other is really important. We're not just doing these two studies in parallel, and there will be some mixed methods analysis at the end as well. I think that is probably the most challenging part of a piece of work like this. Yeah,
that's really useful, especially for some of our human scientists who will be learning about these kind of methodologies. So thank you. Abby has just come back and said thank you to Tessa. I agree, super difficult. Yeah. We've got another question which you kind of answered already, but I'm very curious about how COVID has affected walking groups. So you mentioned the communication methods have changed, but I assume in lockdown they can't meet for walking groups anymore.
Yeah, I'm afraid I don't know. I haven't kept up to date beyond that initial sort of finding out what was happening right after lockdown. But I would imagine that, and I think groups were carrying on over the summer once the worst of lockdown was over in a socially distanced way, because groups of people could meet outside for a bit, but of course now they're not happening. So it will be very disruptive. And given that walking groups have the sustainability issues that I've mentioned, particularly around leadership, because they rely on leaders, that if things have been disrupted, it's possible that some of them will disappear, I think.
Thank you very much. We've got a couple more questions. So thank you for a fascinating talk. Are you able to discuss whether, this is my question, whether we see walking groups striving to improve, so beating time or walking further, and also whether walking groups do things like going away for weekends or picnics or restaurants and things like that?
Yeah, so there's one of the studies that contributed to the meta-ethnography by Coppleton et al. Is really interesting on this, and that group was set up as a way of encouraging people to be more active, and people were given pedometers, and the leader did exercises with people before and after the walks, and her analysis shows how people just basically over time ignored the pedometers. They weren't interested in that. They didn't want to engage with that side of it. They wanted to be together and to be sociable. So I think that's another example in practice, I guess, of what I was talking about, of an initial engagement with walking groups often being about concerns to pursue fitness and health, but that actually dropping away, and that becomes much less important, which isn't to say that people are then not active. They are, but they're not so much thinking about being active in order to be healthy. They're actually enjoying it. And I think that's an important message to take into public health messaging, really, that perhaps we're more likely to engage people if we promote physical activity as being fun rather than as being, this is how you should get out and achieve that 30 minutes of moderate to vigorous physical activity that you ought to be engaging in. In terms of meeting, and I know that sometimes you get groups splintering and expanding, and so I think, yes, there are occasions when groups become more than they initially started as. Sometimes there are people who want to go further than is possible within the framework of some of these schemes, which are quite restrictive about how long walks can be, and so they'll set up a longer and more intense walk. Similarly, there are actually sometimes groups that set up smaller and shorter walks with benches along the way for people who are not able to do the full thing. So they are they're not fixed entities, they do expand. They also generally involve coffee and cakes afterwards. That is a very important part of a walking group.
That sounds like a walking group I could get behind. And actually, now that you mentioned coffee and cake, my mind goes to dogs. You haven't mentioned dogs at all. Is this a common thing? Do people bring dogs? Is it encouraged? Is it discouraged?
I think it varies. So the walk that I joined recently, there were no dogs. I don't think there were rules about dogs, but a lot of it is on the street. There wouldn't have been much opportunity to let a dog off the lead, but definitely there are dogs that go along to other groups. I guess probably depends on the kind of area. I'm sure I have read studies where engagement with dogs and other people's dogs, then gives you a chance to walk with other people's dogs, has been quite important.
Thank you. We've got just one more question, and if anyone is finishing writing the questions, just send those in. Otherwise, this will be the last question. What is a potential solution to the fact that many disadvantaged people who live in cities, such as in London, don't live near large green spaces? And is pollution a worry? I presume if you're walking in city areas, is pollution a worry?
I guess pollution is a worry, isn't it? There's of course very little that walking groups could do about that. I think most walking groups do try to use green spaces as they're available, and even if they're not large parks, they might just be smaller areas. They might be canals that people appreciate, blue spaces as well as green spaces. So I think walking group leaders are often quite creative about using little bits of green space and also exploring new areas. So one of the things that people enjoyed in some of the more urban groups that Steph walked with was just exploring the local area, exploring history as well as nature, and being shown parts of the area that they knew but they didn't know the history of. So there's different ways to engage with the local environment. I think, and walking groups don't necessarily rely on access to those big parks or big rural areas. They can be done creatively in different kinds of areas as well.
Thank you very much. Thank you very much to Tessa for agreeing to come along today and giving that fascinating presentation. I think it's given us all a lot to think about, especially because we're stuck indoors and walking is such a lifeline for many of us. It's also great to see an ex-human scientist at Oxford and somebody employing mixed methods, which we hear a lot about, but we don't necessarily see a lot of in our course at the moment. Next week, we will be hearing from Professor Sir Richard Peto, who will be talking about halving premature death. So please join us for next week. But for now, thank you very much to Tessa for joining us.